of the Irish Forum for Global Health. And I welcome you to this two-day event, Global Health Exchange, Revisiting Health for All in the Era of the SDGs. First announcement, switch off your phones. Yesterday, Joseph Stiglitz, the Nobel Prize-winning economist, did an interview in The Guardian, and he talked about the threefold threat which the world is faced with at the moment. Firstly, the rising tide of inequalities. Secondly, the undermining of democracy. And thirdly, climate change. So our world is living under a darkening cloud with the election of Bolsonaro in Brazil a week ago. And we are meeting today and tomorrow in the shadow of the midterm elections in the United States. But we are coming together in our shared commitment to the ideal of health for all, which was outlined in the Alma-Ata Declaration and the World Health Assembly in 1978 and has been renewed on a number of occasions, most recently in the Sustainable Development Goals in 2015, which are being implemented now in a more complex and a more fragile world than we faced 40 years ago. It is at times such as these that we need to come together to learn from each other and to renew our hope, our courage, and our vision in the struggle for health. Those of you who have worked in this field for some decades will recognize that. That's the title of a book by one of the early pioneers, David Saunders, with whom I worked. We wish to welcome and thank those especially who have come here from afar to speak, contribute, and participate in this exchange. This afternoon we will be kicking off with a plenary of speakers both from afar, from Malawi and from Ireland. And we will see that wealthy and poor countries actually share some of the similar challenges around equity in the pursuit of universal health coverage. And while it's true to say that wealthy countries bear a greater responsibility, and those who are wealthy within such countries, it is the responsibility of all of us to come up with solutions to these challenges. This event is the outcome of a huge amount of work by a small number of people who we will be crediting for their work and naming hopefully tomorrow. By hosting the Irish Forum for Global Health Secretariat in my department, I've got to see the enthusiasm that particularly young people who have come through in global health out of the Masters in Trinity and out of other development programs in Ireland are bringing to these challenges. And I think that's been what's most inspiring, and I think we will be seeing that over today and tomorrow. The increasingly fruitful partnership between RCSI and the Irish Forum for Global Health is something that I think we both recognise and both cherish. So you're all very welcome, and at this point I would like to hand over to the Chair of the Irish Forum, Professor Anne Matthews, who will guide us through today and tomorrow. Thank you.
Thanks very much, Ruairi, and thanks everybody for being so prompt in your attendance here today and so enthusiastic. We can already hear some great conversations happening. So I won't take too much time because we're keen to hear from our first speakers, but just to really set this conference today in context. We wanted to call it a global health exchange rather than the more formal word conference, but we also needed to maybe clarify what it was. So we're somewhere between an exchange, which is a little looser, and a conference. So we're delighted that many people submitted to present, and we've some lovely posters, and we'll have some videos and snapshots and soapboxes. So we really wanted to create as much discussion, dialogue as possible. Those of you who are presenting will know we've kept our time slots quite short. So we want you to get to know a little bit more about each other without maybe, having as long as you might have at a traditional conference. So we're hoping, and I think we guess that will bring about a lot of exchanges. There's a lot of people who know each other very well, and we see lots of new connections forming as well, and that's really the main purpose of the forum itself. Our theme in the forum for this year is Ireland Health and the SDGs, so you can see the SDGs being displayed around the room, and so our conference today and many of our other events fall in with that theme. And what we're trying to do, and I think we'll see this as Ruairi mentioned in the first session, is link those issues that we have more locally with issues that were maybe traditionally we've more focused on in the countries overseas within which we work and others study, and particularly Irish Aid are focused. So you'll hear a lot more about the conference. We're so happy that we've about 100 people who'll be joining us over the couple of days. We've 40 people presenting and lots of plenary speakers, lots of those more dynamic, informal and maybe shorter opportunities as well. I should say our plenary speakers are very dynamic as well. The programme you have, we're going to stick to that as best we can for time. We've lots of volunteers who are also finding their way around a new building, so we'll direct you as best we can between the sessions. We're very grateful to the RCSI for hosting the conference today. As Ruairi said, it is a collaborative conference between Goal, Geraldine and Mary and Claire and colleagues with Goal, RCSI and the Irish Forum for Global Health, and that's the way we all work best. So some of the highlights that you'll come across over the next couple of days: we have the launch of the Irish Forum for Global Health Strategy 2018 to 2023 this evening. Will be launched by Maureen O'Sullivan TD, who'll be known to most people. Tomorrow lunchtime we have the beginning of a discussion about the potential to have a Women in Global Health chapter as part of the global movement in Ireland. We have the Global Health Rights team. You can see around with Ian, and they'll be approaching you hopefully for maybe small little interviews if you consent. They'll be taking photographs. They're being really our correspondents for the conference. Again, they've had some training, and we're grateful for that to help get the new encourage the new generation of global health advocates. We have tomorrow morning at 8 o'clock, because we know students are up very early, we have the student and young professional breakfast session at 8 a.m. And a student competition there as well. So that'll really be important, as Ruairi said, for continuing this work. The conference is being live streamed online, so you can follow that up later on as well as participating here. So we welcome our online participants. The Wi-Fi code is in your pack, and those who use Twitter, some people are very good at tweeting, I know that. It's hashtag GHE, so Global Health Exchange Conference, GHE Conference. There is an evaluation sheet in your pack, and sorry to say that from the very beginning, but especially if you can't stay for the whole event, please complete that so that we learn. As I mentioned, we've lots of volunteers. They've the green signs around their necks, so ask for any assistance you need. Really just remains for me to thank Irish Aid for the support for the Irish Forum for Global Health overall, and for the support for the conference today. And we're lucky to have a speaker from Irish Aid in the first session. So just from a safety point of view, if there is a fire alarm or any other alert, follow the green signs towards the fire exits and keep following them until you're in an assembly point. So that's everything from a practical and overview point of view. The SDGs, as Ruairi said, are being displayed around the room. This, we know we have our own responsibility in Ireland, and we reported our voluntary report during the summer. So what we want to do is maybe over the 2 days capture people, find yourself drawn towards one of the SDGs or all of them, if some of us have inclinations towards one or another, and some of our volunteers will ask, can they take your photograph with some of those? So we really want to help join that movement, the SDG movement in Ireland and internationally. So, having spoken for longer than I should, I'll pass over to Mary van Lieshout, who many people will know. She's the head of ethics and compliance at Goal, and she'll chair the first session. So, thank you, Mary.
Thank you. Thank you. Thanks, Anne. Thanks, Anne. And just before we start, I just want to say what an exciting program and what an exciting range of activities are planned for the next couple of days. So I do hope we see some of you tweeting about some of the new ways of working and exchange here that are present in your program. So congratulations to the organizers. It's been a real privilege for Goal to be part of this process, which really began with conversations a few years ago. Credit to our colleagues and for collaboration, which brings out the best in all of us. We have 3 really exciting speakers for the first session, and where better to start than at that global sort of challenge of reducing health inequalities and making sure that those furthest behind are at the front of our thoughts. Our first speaker is Sara Burke. You'll see more in your packs about Sara Burke. Suffice to say, Sara is one of Ireland's leading health policy advocates. She has carved her reputation on fighting health inequalities. Her seminal book in 2009, Irish Apartheid, Healthcare Inequality in Ireland, is the textbook on how our health services needed to continue to reflect to ensure that people in Ireland saw an enriched experience of healthcare provision and a reduced experience of those inequalities that so plague us. So I want to introduce and welcome Sara Burke to the podium. Start us off. Thanks.
Sorry. I probably don't need the step up. Anyway, I actually have a habit in summer of taking my high heels off at conferences so I can get down to the mic, but I'll spare you that as it's winter time. Okay, good afternoon, everybody. Thank you very much for inviting me here today, and it really is an honour, if somewhat a surprise, to be invited to kick off this Global Health Forum. Anita Friel very casually asked me to do something at this ages ago, and I said sure, and I didn't think I'd be the beginning of the running order. But I'm particularly interested in the theme of health for all and leaving no one behind. And I think it's a very useful, obviously, to think about this at a global level, but I'm a real believer that we need to learn to do at home what we advocate to do abroad. No, you don't have my slides. Okay, I'll try and find them here. Will somebody else try and do that, and I'll keep going. Okay, I was just thinking in advance of today, because it was Anita and Ruairi Brugha who both independently asked me to have an input into this today. And in one of those funny circles of life, it's exactly 10 years ago since I started my PhD, which was a PhD program run between RCSI, Trinity and UCC, a program that's become the Sphere program, which I'm now the module lead on health policy and health systems. And it was because of Ruairi Brugha I have taken this diversion, or perhaps conversion in life. I'm a very reluctant academic. Still feel it's a bit weird to even say I'm an academic, but I'd written an article in the Irish Times about the fiasco of the establishment of the HSE, and out of the blue, Ruairi emailed me suggesting I apply for one of the scholarships on this new PhD program, and I emailed him back going, I have no interest in academia, go away. And he said, well, let's meet for coffee. And to be honest, the only reason I went to meet him for coffee was because of his surname, and I thought, oh, interesting. A radical academic, very unusual in Irish context, with the surname of Brugha. Anyway, he persuaded me to do it, and actually it was in this building I was interviewed, and it was Hannah McGee, who's now Dean of Medicine here, and Anne Hickey, a professor here, who interviewed me, and I gave a scathing critique of Irish academia and the ivory towers that the academics sat in, and how they/we are part of the problem. And they sort of tossed it back to me and offered me a place on the program and suggested that I become part of trying to solve that problem. And thus it is so I've been invited here today to give this very high-level overview of the Irish health system. How Just tell me which button to go next. That one, okay. And I was told I had 15 minutes to do it, and then somebody subsequently told me I had 20 minutes to do it. So slightly mission impossible, okay, because in the next 15, 17 minutes, I'm going to give you a high-level overview of the Irish health system, and actually I'm going to spend quite a bit of time just on some very high-level indicators of where we're at in an Irish context. And then a recent, again, very much just quick helicopter overview of where we are in relation to policy developments, and in particular the recent Slóinte report, which was produced by an all-party parliamentary committee, a Oireachtas committee, we call it in Ireland, on the future of healthcare. Oh, I've forgotten how to do this now. Okay, and this work will draw on the research project that is just finishing up at the moment that I coordinate in Trinity called Mapping the Pathways to Universal Healthcare, but also my previous postdoc, which was called the Resilience Project, which was trying to benchmark where we were at in terms of what happened to the health system during the economic crisis. So the names on the front slide, it's very much a team effort and drawing on this team's work, not just my work. And as part of this HRB work, very sort of coincidentally, the Oireachtas committee was set up during that time, and I will talk a bit more about that. But one of its remit was to deliver a plan around universal healthcare, which is exactly what we were trying to do academically. And so the project got delayed because we stopped for 6 months and worked directly with that Oireachtas committee. So I will also draw on that experience and privilege really of having spent 15, 20 years critiquing and commenting and researching and analysing the policy from the outside, of having that 6 months of working also on the inside. I was asked to pitch this like I was talking to an audience who knew nothing about the Irish health system. So apologies to those of you who are very familiar with the issues here. But also sometimes I think it is quite useful for us just to take a step back. And you'll note my previous slide has that much prettier aerial map of Ireland. But I guess when we're talking about policy and systems, it is the policy and the system of the Republic in Ireland that most of my research is concerned with. We're a small population of under 5 million people. Our demographics are behind the European OECD norm, so we're slightly younger than the rest of the OECD. We have a higher fertility rate than most of our European partners. We were one of the countries who experienced the worst brunt of the international financial crisis, which became a very severe home economic crisis, driven by external circumstances, but also really poor public fiscal and economic policies of consecutive governments in Ireland. And there was huge cuts across public expenditure, but it was actually health that bore the brunt of those cuts more so than any other sector. And then what we've seen since 2015 is this huge escalating economic growth, again breaking all international growth rate norms, which I think seems odd to people who are living here because it mightn't feel that. But when you look at our figures, our GDP rates of growth are very high and slightly similar to how they were pre-bust. In terms of our health system, and I don't think I can say it enough, we have no universal health system in Ireland. There's no legal entitlement to health and social care, and we have this extremely complex system of eligibility that has its origins in legislation written in 1970, so nearly 50 years ago, but actually has its origins in the Poor Law, which was imposed on Ireland in 1838 by our British rulers, and very much produced a poor system for the poor people. And I think that helps explain some of our inability to get out of that and develop a universal health system up to now. The 1970 Health Act divides the population into Category 1 and Category 2, which is basically people who are poor enough, usually to have medical cards, about a third of the population, and 2/3 of the population who don't have medical cards. But actually it's much more complicated than that, and there's layers and layers on top of it. But the most notable layer when I'm presenting internationally is that nearly half the population have private voluntary health insurance. So we've extremely high rates of uptake of health insurance for a system that is not compulsory. And actually a health insurance system that buys you very little. And this is pretty much the same slide as previously, but it's just showing you the breakdown of our publicly funded system, or of our entire health budget. So just under 70% is tax funded. Sort of depends which stats we use, but this is WHO stats, which show about 15% is out-of-pocket spending, 15% is private health insurance. And within that, we have high health status inequalities, but high unmet need and poor access. And this is our composition of health spending across I think it's the European 28 countries for 2014, just because that's the only one that's currently available. And again, that shows that solidarity funding, or public funding, well below the EU 28, where we're ringed there, sort of in the bottom half. And that's because of our high out-of-pocket expenditure, but also high uptake of private health insurance. So when you hear our political leaders say we've a very expensive system of healthcare, they're referring to the overall expenditure in health rather than the public expenditure in health. And when you look at our public expenditure in health, we're still below or about the EU norm. Just in terms of health inequalities, our life expectancy has increased significantly over recent decades, reflecting improvements in quality of life and the determinants of health. We're now above the EU norm of average of life expectancy. But as you can see from the bottom of this chart, we still have these significant inequalities between rich and poor, with 5-6 years difference in life expectancy between the people on the lower socioeconomic groups and the people on the higher socioeconomic groups. And this inequality has persisted even as inequality, or our life expectancy has increased. We have extremely high levels of unmet need, which aren't always caught in survey data, and there's lots of reasons for that, but part of it is we always rate ourselves. When everybody self-reported health in Ireland, the general answer is, sure, I'm grand, even if you're not grand at all. So there's real problems with our unmet need data, but there is recent better data, which is the European Health Information Survey, which shows that we've the second highest unmet need for healthcare across Europe, way above the European average at 40%, the European average at 26%. And what this chart shows at the bottom is just that unmet need for all aspects, or many aspects, of health and social care. So for medical care, which is hospital, outpatient, GP appointments, dental care, mental health care, and prescribed medicines. So huge amounts of unmet need. And in terms of access, and again, it's difficult to get time series reliable data over time, but we have some, and this is your first outpatient appointment. So this is the time when you go to see your GP and your GP decides you need to see a specialist, to that first specialist appointment. And the HSE changed how it counted this. They sort of stopped counting. The figures were so high in 2009 to 2010, they stopped counting and then they started again, but they're not, you can't continue the series. So we have to start in 2012. But what this shows is hundreds of thousands of people looking for care, and the international norm is 0 to 3 months, that it's okay unless it's an emergency to be seen within 3 months. It's considered a reasonable period of time. And the green is the 3 months, and you can see there the green is rather steady. But what's increasing is the 3 to 6 months, which is the blue, the 6 to 12 months, which is the red, and the over 12 months. So this is for your first appointment with a specialist when you're sick and in need of diagnosis or treatment. And this shows about 130,000 individuals waiting for that first appointment. Our waiting list data is appalling. It wouldn't pass any benchmark of international best practice, because we have various different waiting lists rather than a whole waiting list time. And so this is the data from when you get to see your specialist and you're determined that treatment is needed, which is about 1 in 10 of those who go to a specialist. So these figures, the N is much lower, it's 80,000 people. And again, the 0 to 3 months, the green bar is within the absolute norm. But it's the blue, red, and yellow where you're waiting months or years. And if you combine those two, you will see that hundreds of thousands and tens of thousands of Ireland wait years from diagnosis to treatment within the public hospital system. A lot of the work I've done with the Pathways project has been in an EU context, and they're always, with the WHO, and the WHO are always trying to get us to fill out this box for Ireland. And it ruined a summer of my life because I couldn't work out how to put that into a 3D box, right? And actually, the content in it is irrelevant, right? But if we just go very briefly back to it. So this is like, under a universal health system, who is covered? So it's universal, everybody is covered. So how do you move to everybody being covered? What services are covered? And how financially protected are citizens for achieving that care? And what this was is sort of a snapshot in time of what it was like 2016, 2017, actually I updated it for the RCSI report, but really the only aspect of universalism within the Irish health system is our vaccinations, our screenings, and the maternal and infant care scheme. There's no other aspect of it that is truly universal. And in terms of why this is important, we know that this unequal system of care, that the inverse care law, perpetuates inequalities, that it creates poorer outcomes for people. People with delayed diagnosis need more medical intervention that's more costly, but also detrimental to their health and their quality of life. But in some instances can be fatal, that delayed access to care. And we are extremely unusual in an OECD, European context that we have no universal primary care, that we directly funnel people into the most expensive places to get care, usually the hospital system, that we have a system that incentivizes doctors and hospitals to treat private patients even within the public hospital system. We've high unmet need, poor financial protection, and there's this sort of, people say that a medical card actually protects the poorest, and recent research we've done in Trinity around financial protection shows that actually even the smallest of charges introduced during austerity has pushed the poorest into catastrophic spending and financial hardship. Okay, now I spent way too much on that because I have 5 minutes to go. Okay, so we've got to speed up. I just throw this in as a last one, which was what happened during the economic crisis. And what it maps is the two bottom ones, the red and the purple, is the cuts to the budget and the staff. So there was huge cuts to public budgets and public staffing. And what the other lines show is the yellow at the top is a huge increase in day cases. So we did way more day cases, triggered really by the financial crisis. Inpatient care sort of leveled off. But the only bits of the health system that didn't stop didn't level out or go down were emergency presentations and emergency admissions. And so this slide tells us lots of things. I could actually spend 2 hours on this slide, but the sort of key messages is that the system actually did manage to do more with less in the first few years of the crisis. And then it got to a point where it had no choice but to do less with less, except for the areas where it couldn't stop people coming in the door, because happily in Ireland, if you present for emergency care and need it, you will get it. But what's beneath all this also is that actually we've made significant improvements in care during this. So I know I've painted a pretty grim picture with this high-level overview, but there have been significant improvements in cancer services, in palliative care, in stroke services. So against the odds, many frontline clinicians and teams have managed to improve care within the public system in this extremely difficult environment. And if we are to sort of trace Ireland's health policy development, we can probably see 2 or 3 or 4 different eras. The 2000 to 2009, where there was a quadrupling of the health budget, this constant reorganisation of structures without any real reform, and this very silent but effective privatisation of huge aspects of healthcare. And then 2009 to 2014, a system sort of paralysed by austerity that put more charges onto people, that increasingly rationed care. And very ambitious reforms, one of which was universal health insurance, happily were not realised. And then from 2014 to 2016, this stabilising of the health budget and the development of this all-party committee on the future of healthcare. And we're in this potential area now of increasing health budgets and with Sláinte Care there as a policy document, and that's why I say we're at this critical juncture. I have 2 minutes to give you your crash course on Sláinte Care. Okay. Again, don't worry about the detail of this. Basically, the committee was set up after a general election when, in short, nobody knew what else to do about health. So let's set up an all-party committee and give them a remit to develop a 10-year plan to devise a universal health system. They reported a year later. For 15 months, very little happened and in August and September of this year, the Department of Health produced a response to it, which is a pretty shoddy implementation strategy that I gave a good critique to about 6 weeks ago, and I'll spare you the detail of. And they have set up an office to drive that reform. And key to Sláinte Care are these 4 areas. So bringing us up to the norm about legislating for an entitlement to care, but also around wait time, so that you're not entitled to a service that you can't get, that you'll get that service within a period of time. Huge reorientation and a boost for the system towards primary care, much more services outside of hospital, much better public health, much more integrated care with the person at the centre of it. Facilitated through workforce expansion and critically e-health. A costed plan to do it, and an implementation office to drive the reform. And one of the elements in there is the removal of private care from public hospitals. The vision was kept in the implementation plan, and some of the implementation plan is quite good. It's strong on public health, it's strong on non-hospital care, it's quite good on an implementation structure. It has good new ideas around a citizen care master plan, mobilising people to get behind the need for health reform, and critically, the engagement of people working in the health system, people who are weary and tired from constant reform, from huge media and public bashing, and getting them to drive the reform, because we know health reform only really works when you have that leadership from the front within, or from the bottom within the health system. So, I was really struggling with how optimistic or pessimistic I could be today, and I've tried to steer it somewhere in the middle. We've never had political consensus on health reform in Ireland, so it is a huge achievement that there is a plan there that was devised by politicians, and it is a roadmap to deliver a universal health system. So it's the first time in the history of the state, we're nearly 100 years old, and it's the first time we have a plan to deliver universalism. There is an office with a great woman at its helm, and momentum to drive that reform, and commitments to engaging citizens and staff within the system, and I think that's really positive. But within the Department of Health response, there's also a backtracking on universalism, and instead of using the word entitlement, they go back to the 1840s or the 1970s language of eligibility. It's like they just don't understand it. It's much less ambitious in terms of the politicians' report was getting some quick wins, getting the people on board and driving the reform before the vested interests gathered and stopped it. And there's been quite a bit of long fingering in the new report. The budget allocated for next year is nowhere near what's required to implement Sláinte Care. So in conclusion, we know that reform of this kind is hard to deliver and will be and is being opposed by vested interest, and that in a way it's easier to stay on the inefficient, unequal track we're on. We know that past dependency, that previous form, is a very good predictor of future performance. But I'd argue that we've no choice but to reform, that our current system is unsustainable, it's unfair, and it doesn't deliver the health and social care system that those in Ireland should expect and be entitled to. That said, we know that policy change to reduce health inequalities, to tackle inequalities in access to services, to deliver universal healthcare, requires progressive action. It requires really active action, that's a terrible word, progressive action, which can only be realised through enormous political courage, commitment and momentum. And I do think we're at a critical choice in Ireland, where we as people, as citizens or people who live here, have a chance to influence our political leaders to choose the opportunity that Sláinte Care brings to break from the path we're on and work towards a universal health system for all, where no one is left behind. Thank you very much.
Okay, guys, a really excellent start to this exciting conference. Sarah, I'm going to allow one question just before we go into our second speaker, and if we don't have one, that'll provide an opportunity for more comparative questions later on. Anybody, a point of clarification or something you want to take up with Sarah before we move on? Okay, nobody's going to be forced, but I see. Roz, thank you.
Hi, Sarah, thank you very much. Just interested in the Oireachtas group's deliberations and why social care is not really included in launching care. It's more sort of the classic health system as opposed to including social care, which is funded by the IFGH.
Great question. Hard to answer. A couple of reasons. The brief was so enormous that there wasn't the time or the data to do justice to the social care stuff. So it's alluded to in there, but the detail absolutely is not there. Now, the entitlements are, and the legislation is for a universal entitlement to all health and social care. So it's very much considered to be included, but we just don't have the data to either cost, the unmet need, or the level of services that were needed, and I think that's why it's not in there.
Okay, thanks for that question from the National Disability Authority, actually. Okay, thank you. Sarah, can I ask you to join us back here, and we'll welcome Lusungu. Oh, I think it's Lusungu first. Okay, I got it. Aidan, we are saving. I am not going to do a cliche, but it's the best, and the best, but the second best is Lusungu Dzinkambani. Lusungu works with Oxfam in Malawi, and she's been a health champion for universal health coverage in Malawi for many years. And Oxfam is really honored to have her, not only working for them, but able to come here and share what they're trying to achieve in terms of health system strengthening and access for all in Malawi. A very different system, but let's hear what the activists and the policy people are doing in Malawi. Thank you, Lusungu. I think only Aidan's going to use this stuff.
Thank you so much. Thank you for having me here. I'm so glad that I was able to come and be with you in this session. I would like to share with you the story of Malawi. So basically, I'm talking about our journey in terms of achieving universal health coverage. I'll talk about the successes that we've had as a country and also the challenges that we've met in the process. So I'm talking about Malawi. Glad that there are a number of people here who've been to Malawi or who work with Malawi or who know Malawi. So it's called the warm heart of Africa. It's a very beautiful country, very nice scenery, very nice people, and yeah, very beautiful all in all. Yeah, so I think coming to the basics about the country, we were a British colony. We got independent in 1964. We have quite a big population of about 17 million people. Our economy is dependent on agriculture, and it's mostly rain-fed agriculture and largely subsistence farming. So basically, the climatic conditions that have been happening recently, the global warming and issue, have got quite a big effect on our climate and on our agriculture productivity. Like for about the past 5 years, we've had droughts or floods, which have really affected our production. We are a relatively poor country. Our GDP per capita is 1,200. IMF ranks us one of the third poorest country in the world. About more than 50% of the population live below $1 a day, so that's the poverty line. So actually, the figures go. Some estimates are even much higher. Life expectancy, according to the UN, it's at 54.8%. Of course, there are other other bodies that peg it at a different rate. So I've used the UN rate. And then, as a country, we've apart from really being a poor country, we've had a big challenge of growing in inequalities. In just a period of 7 years, the gap between the richest 10% and the bottom 40% has grown by almost a third. And it is estimated that if nothing happens, by 2020, there will be 1.5 million more Malawians being pushed below poverty line. Okay, so basically my talk today, I basically want to defend my and Oxfam and other CSOs' idea that universal health coverage, its achievement or lack of it, it's a matter of choice. It's not really an economic issue. For me, it's rather a political or an issue that we decide. We decide whether we want to achieve universal health coverage or not. And even for a poor country like Malawi, there are decisions which we can make working towards universal health coverage. So I think the first picture that I would want to push is that as a country, we've done some decisions that have made us to choose not to leave anyone behind when it comes to universal health coverage. I think the first thing that we are proud of Malawians, we are proud of as Malawians, is that I think there have been times when we've resisted to pressures by other institutions that have maybe really suggested measures that we feel would leave other people behind in terms of universal health coverage. For example, around the 90s, the late 80s, 90s, when there was that push during the structural adjustment programs around around countries introducing user fees for health, Malawi as a country, we decided we are not going that way, and we feel it made quite a significant improvement in terms of our health, our journey towards universal health coverage. So I think, therefore, since we made that decision, we've been financing our health system mainly through tax and donor aid. And generally what it has meant is that health services is free at the point of access. So if I go to a public hospital, I do not have to pay anything to access health services, which for a country like Malawi, where a majority of us are poor, it is very important to have free access to health services. And then, apart from that, we do appreciate that there are some sections of the country that are not covered. Government has gone on to make service level agreements, mainly with health facilities that are provided by a Christian NGO group. So whereby what happens is that for every facility that is not covered or that is outside the government covered area, so that's for the radius of 8 kilometers and having a population of about 7,000, government pays these private facilities to provide health services, especially the essential health services to the public. And then the other thing that Malawi chose was basically the choice to have an essential health package. So basically, Malawi has a package of health services that are mandatory to be provided at every facility. So this package has got like, it has got things like treatment for basic common illnesses, HIV, some non-communicable diseases, maternity care. So it is a package that is mandatory and really guides the services that each health facility can provide. Secondly, the government has really, in terms of our health strategic plan, it has been clear and it has been deliberately put in place a policy that works towards achieving universal health coverage. So universal health coverage tops the agenda. As you can see on the far right, that's our strategic health strategic plan covering 2017 to 2022. It clearly has towards universal health coverage as part of the agenda. And I think because of that, that's why I think as a country, despite our economic situation, we were able to achieve MDG4, which is around infant mortality, much faster than our neighbors. And then, having said about the progressive choices that we've made as a country, there have been situations where we've also made some choices that haven't been good. I think one of the things is that as a country, we've not been very good at curbing corruption. There are big levels of corruption in the country. Like in 2014, there was a big cashgate scandal where a lot of money was siphoned from the private coffers, like directly from the central government. So I think that that also led to donor withdrawal of direct budgetary support. So it was basically a decision that government made so that they're putting less effort in curbing corruption, and then it is affecting aid, which is a big contributor to Malawi's health financing. And then also there has been less commitment by government to address inefficiencies in health service delivery. There are high cases of drug pilferages, high cases of pure procurement inefficiencies, and a lot of other inefficiencies. And I think as a result of those poor choices, we've had poor health service delivery, inadequate drugs and suppliers, and also inadequate staff in the facilities. Okay, and then also further, going further in terms of the retrogressive choices, because of the dwindling public resource, government is now exploring a lot of other retrogressive means. For instance, there's been there's been a lot of exploration around user fees in the health facilities. Like you can see on the newspaper caption, there's been to and fro battle in terms of exploring hospital user fees. And currently what government has introduced is a bypass fee for health facilities. So basically, there is a requirement that everyone should be going to a primary health facility, and then they should be referred to a tertiary level facilities. But what happens in my country is that in most cases, there are some areas that are covered by a tertiary facility that do not have a primary healthcare facility. And then apart from that, the primary health facilities are generally not functional. You find that there's inadequate staff, inadequate drug. So by the end of the day, they're asking people to pay about 2 to 3 euros if they want to bypass the primary facility. However, because of the poor condition of the primary facility, basically people are forced to bypass. Otherwise, if they do not bypass, it means they are missing out the health service at all. So basically, that is the situation. So basically, this bypass fees which has been introduced is somehow pushing the already poor people further into poverty because they're being forced to pay while the facility which is being proposed to cater for them is not functional. So basically, looking at the out-of-pocket mechanisms that are being proposed are basically fueling economic inequalities because people now, the poor, have to spend much bigger proportion of their wealth on health expenses, and then they are negatively affecting the redistributive potential of health investments. And then in terms of going further, in terms of the retrogressive choices that my government has done, one of the key things is the decrease in budgetary allocation to health. Malawi is a signatory to the Abuja Declaration, where we made a commitment that we are going to at least allocate 15% of our national health budget to health. However, over the past years, that hasn't happened. You can look at the graph there. In 2013 to 2014, we were 12%. But over the years, we've been decreasing to below 9%. So that is a big challenge. And then I think the retrogressive choices haven't just been made by government. When you look at donors as well, donors now have chosen to do an off-budget support. So it basically means they've got their own priorities, and sometimes the priorities do not match the government's priorities. So that is also affecting health service delivery in the process. But also, I think as a country, we've chosen to maintain retrogressive treaties that are supporting developing countries. Like, for instance, Malawi has got treaties with countries like the UK, the Netherlands, Norway, and France that basically exempt those countries. Goods produced in Malawi exported to those countries, they are exempted from tax. And basically that tax could have some significant support towards provision of essential services such as health. So basically we are saying that the fact that we are accepting those treaties to go on, and mind you, these treaties were negotiated during the colonial era. So they are not recent treaties. They were negotiated during the colonial era when the bargaining powers were very unequal. And then I just wanted to share a bit in terms of, after looking at the context, there's a lot that us as civil society organizations, so Oxfam and our partners, and I think on this work in terms of Oxfam, we are mainly supported by Irish Aid in terms of what we are doing as civil society organization. I think, first of all, we are working together with other civil society organizations to make sure that we are working with communities and make sure that we are helping them to make demands. Currently, the situation in my country is a lot of decision makers make decisions that do not necessarily favor the poor people. So you really need to have citizens' action to make those demands if we're going to have good access to health services. I'll show a brief video about that, around that. Just a minute, yeah. And then the other thing that we are doing, sorry, thank you. The other thing that we are doing is that we are doing a lot of advocacy. So we formed, we've mobilized ourselves into our Universal Health Coverage Coalition, where as CSOs we are coming together and advocating for universal health coverage. And also we are doing a lot of research and getting information to inform our health policy, our health policy suggestions. We've had a number of students from the Trinity College supporting us. So there are 2 research papers that have come from Ireland and from Trinity College that has really informed our policy action around health. So yeah, briefly, I'll show you a video. It's basically around how we've worked with communities to make sure that they are demanding an address of injustices that are happening in terms of access to health services. Sorry. Okay, we'll get. Yeah, sure.
Malawi's health sector is rocked by countless problems, including inadequate ambulances, water shortages at health facilities, inadequate personnel and budgetary allocation, unfriendly health personnel, drug shortages, and the list is too long to exhaust. Serving a population of over 20,000 people, Mpimbi Health Center was allocated a vehicle ambulance to help ferry referral patients to a district hospital which is 63 kilometers away. However, authorities from the district health office withdrew the ambulance from the facility, and this rendered patients in need helpless. All referral patients and pregnant women needing special treatment resorted to using public transport to go to the district hospital and were not accompanied by any medical personnel.
Nimene ninkajira ine anzanga mene aba patient anzanga amunawo tibyawe amazilarani inasompoka kumasankasaza yani magazi ayonda ine amasanganikirana ndipo padayi pacho chitiro chachikulu panthawi imeneyo mudalibe nesina yonse kuti ngati unitani undithandiza.
Vuto limeneli sila lero ndilakalekale ndila zaka zingapo zapitazo. Komano chifukwa tinalibe upangiri sitimadziwa timaona ngati kunono ambulance kokhala kwawo ndi kumene yapita kuja ngakhale idabwera kunoko zoti ndi athu umwini ife sitimadziwa china chilichonse. Komano kubwera kwa bungwe lija la DCT Development Communications Trust amene amalandira thandizo lawo ku Oxfam anatifotokozera ndi maphunziro ndipo maphunziro amenewo anatipangano ifeyo kuzindikira kukwecheka m'maso kudziwa kuti ambulance ija ndiyoyenera kukhala pachani pachipatala pano. Tsono maphunziro aja anatipangitsa kuti tikumane ndi adindo osiyanasiyana ndi project ija yakulimbikitsa ulamuliro wabwino pa nkhani ya zaumoyo.
Ine ngati gulupu kuti nazoona ndine munthu osangalala kwambiri komanso sindine ndekha komanso ngakhale anthu am'mudzi ndi osangalala kwambiri chifukwa mavuto amene anali kumbuyo panopo achepetsedwa. Mokuti pakakhala mavuto ona kuti wina wake wadwala akufunika chithandizo cha mwamsangamsanga kuti akalandire ku chipatala chachikulu sizikumatenganso nthawi yayitali less than 10 to 15 minutes kupezeka kunena kuti munthu uja wanyamulidwa ndiponso wapita ku chipatala wakalandirira thandizo.
Pano pono tikuyimba lokoma chifukwa choti pa nthawi inoyi matenda kapena maliro achepa chifukwa chani kodi ambulance ija yabwera ili konkuno ku Phimbi. Ndemwayi monga ngati kunoko tikusangala monga ife ahagi ntchito yathu tikuona ngati pano pono ili bwino.
Kaimira chitika nabwera kunoko lapasa sonkhano anakumana ndi ife achipatala kukambirana kuti kodi vuto imene titesa bwanji. Nditakambirana anayitanapo makhansala ma MP anayitanidwa ndi ena amene okhudzidwa ndi yani nkhani ngati zimene anayitanidwa kuti sonkhano wakulu atisi atecho anafikapo sanalipo. Titakambirana simathe nthawi yayitali mwezi sunathe mina masiku ochepa naweza kuti ambulance inabwera ndipo ambulance imakhala pompano.
Thank you so much. So that's an example of some of the work that we do with communities, basically empowering them and helping them in demanding their right to health and generally in terms of action to health services. Okay, and apart from that, I think as CSOs, we come together and we've come up with a number of us where we are continuously engaging government and other stakeholders around this. So basically some of the key issues that we are calling for is that one is we are calling for our government to make sure that they commit to spending at least 15% of our national budget on health. We are calling on them to make sure that they put in place systems that ensure efficient use of resources and curb corruption. We are calling for putting in place strategies that are promoting progressive tax reforms to make sure that we are able to redistribute our economy so that we're able to cover services for the poor people. And I think key, we are also calling for our government to renegotiate the treaties that disadvantage our countries. However, the call is not just to Malawi. We are also calling upon our donors to do a number of actions. First of all, we are calling for them to support the financing of healthcare through stronger and more equitable tax systems, including through collaboration to tackle tax dodging. I think there have been a number of cases in my country where where some institutions do dodge tax, so I think we are really calling for that. We are calling for reform in the donors' home policies around tax dodging, and especially around negotiating to remove those retrogressive tax treaties. And also there's a call to make sure that the donor communities are channeling aid through the government healthcare system, and that they're working to support the strengthening of public financial management systems and generally to advance the aid effectiveness principles.
Thank you very much, Lusungu. Okay, introducing Irish on her last slide and tax dodging on her second last slide. That is very brave. Let's try one question, please, before we move into Aidan. Anybody for a clarification or a question, or we'll have more time later? Okay, thank you, Brita.
Thanks, that's very interesting presentation. Just on the essential health package in Malawi, are HIV testing services included?
Yes, yes, HIV testing and treatment as well.
Excellent.
Thank you.
Okay, great. One question. Okay, thank you, Lusungu. Guys, bringing this all together, for a lot of citizens of Ireland, the connection between a developing country or a southern country like Malawi and the Irish health system is the Department of Foreign Affairs and Trade. Irish Aid makes that connection for many of our citizens. Today we're very, very fortunate to have the Deputy Head of the Policy Unit, Aidan Fitzpatrick, to join us and talk a bit about the new Irish Aid development policy and how that connection, they join up that policy, that experience in Ireland and the concern of our citizens with which we've heard about Malawi. Thanks, Aidan. Well done. Excellent. Excellent.
Good afternoon, everyone. I don't know if I have all the answers. Lovely hearing Lusungu. I had the good fortune to work in Malawi heading up our development program from 2014 to 2016. Whether we met the challenges and the suggestions that Lusungu put out there on the second last slide, I'm not too sure. But let me, in the next few minutes, what I'd like to do is share with you an ongoing process to review our international development policy. I'd like to share a couple of slides on one of the key issues, I think, in delivering universal healthcare, and particularly in reaching the SDG goal 3.8, delivering universal healthcare to everyone. And then just a last couple of slides on what it is we're doing in the health sector and our thoughts going forward on what it is we might do over the coming years. So, yeah, that's what I'd hope to do. Right. The revision of our international development policy. Our present policy dates back to 2012. Last year, more or less this time last year, October, on Budget Day, the Taoiseach, Minister for Foreign Affairs, Simon Coveney, announced the clear intention of the government to move to 0.7 by 2030. That 0.7 commitment, it's something we all signed up to in 1979, a little while back. Some countries have got there. There's about 6 or 7 countries who deliver on that 0.7 commitment year on year. In moving to that 0.7 commitment, the Taoiseach was anxious to have a good development policy to guide that whole process. So working off the DPAR, the Department of Public Expenditure Reform guidelines for formulating new policy, we started into a process, a year into it at this stage, and these are kind of the key milestones in that process. Starting with internal analysis, reaching out to a lot of our colleagues here domestically, reaching out to the 7-8 departments that we work most closely with. That brought us up to May, June. We then got a consultation paper together and then went on the public consultation process. And the public consultation process, we have received 185 substantive written submissions, and I'll give you detail on where they came from. We've got about 14,000 other contributions, mainly through social media. And then we did a number of public consultation meetings, town hall meetings in 5 different locations. I think the breakdown of those 185 submissions, the majority coming from Irish networks and NGOs, next 17% from international networks and NGOs. In total, I think all the submissions, they amounted to about 1 million words, so we're trying to distill that and pull up the best of what is there. The general response from the consultation process, a very warm welcome for the commitment to 0.7 and trying to get there. The centrality of the SDGs, the previous policy had predated the SDGs, so yeah, we need to put the SDGs front and centre in what it is we're trying to do and deliver. The authenticity and the coherence of Ireland's international actions was recognised, and the kind of proposed priorities that came out of that process, or that's coming out of that process. Definitely that whole commitment to leaving no one behind, but we've kind of gone another step with that. Leaving no one behind, you're looking at a community, you're saying, well, who's left behind? You're probably looking at 40, 50, 60, 70% in some cases. What we've committed to is to continue a very clear focus on the poorest. So we're working more with this furthest behind first, trying to ensure that we get the furthest behind first and prioritise those in our work. Clear commitment and a lot of recommendations around gender equality, keeping a focus on gender issues. Climate change really came up a lot, so how we might respond better, build on our existing work and respond better to climate change. reducing humanitarian need, and then governance and human rights. And the kind of interventions that people were encouraging, a lot of this we're doing already, but a definite focus on peace, hunger, and agriculture, education, and health. Some of the challenges that were highlighted during that consultation process. Around protection and prevention, respondents are looking for bold action on fragile states. And possibly commitment to engaging, for example, in South Sudan, a crisis that we have funded for a long time. So we put in humanitarian support in South Sudan. We're putting in about 6 million a year, but we don't have a presence there, and we're not getting in there following that money and seeing what's happening on the ground. So kind of, can we up our engagement in fragile states such as South Sudan? A lot of the contributors highlighted the shrinking civil society space. Civil society within a lot of countries is under increasing pressure. And yeah, a need to be aware of that, and calls for Ireland to take a leadership role in addressing that issue. The movement of people, refugees, and European politics around aid loom large. The whole refugee crisis has challenged what it is we've been doing in aid, and a lot of our money now is heading into addressing the migration crisis. I think it peaked in 2015, I think it was, with Syria. It's dropped back considerably, but it's still a key issue going forward. On food, we're looking at taking a kind of a systems approach to supporting people, a systems approach to addressing the food challenge, the nutrition challenge that is there. So that's looking at, in the context of food, what it is that countries are producing, people's access to it, how those markets are working, are those markets working for the poor? And yeah, how do we address the root causes of hunger? Can we improve what we're already doing? There was a series of suggestions around how to harness Irish experience and expertise. We've come on a very interesting journey here in Ireland in the last 50 years, coming almost from subsistence farming, now exporting food, feeding, I think there's different figures used, but up to 40-50 million people globally with our beef and dairy. A stronger focus on women, again under that food heading, it was called for, and submission to attention to the future, technology, urbanisation, young people, inclusive economic growth demands that we look at these issues in a lot more depth. On the people focus, in health, a focus on bringing people-centred community-level approaches to the fore. In education, accepting that education underpins everything in development, there were a range of proposals for sharpening our focus for impact in the education sector, and a need to do more on development education here domestically to kind of make people more aware of our development efforts and to garner and ensure broad public support for what it is we're doing overseas. So a lot of what we're looking at doing a lot of what it is we've been doing to date, but we will be trying to do it differently, and we'll be trying to do it in a way that has greater impact. So some of the suggestions around that, a clear articulation of rationale, principles, allow the programme to grow in a sustainable way. By reaching point 7, presently we're at point 3. If we're to reach point 7, and point 3, equates to about 700, 800 million a year. If we're to get to point 7, our budgets will grow to between 2 and 2.5 billion by 2030. That's a lot of growth, a lot of expansion. We need to do that in a way that we can manage well and that we can deliver well with. Policy coherence for development, this is a key issue, I think, and it's one thing. The budget that we have, so at the moment it's 0.3 of the national budget. We can do very, very good development work. We can deliver in climate, we can deliver in all these different areas. It's 0.3 of the budget. If the other 99.7% of the budget is going in a different direction or isn't delivering on the SDGs, then yeah, it has to be. The SDGs bring that reality that it has to be a whole of government approach. Cross-government coordination, key, balancing innovation and risk management. We're being challenged to do a lot more with the private sector, and we want to meet that challenge, but we want to do it in a way too that we manage risk. Handing money over to the private sector, public money to private sector, how it's done well, and how it's done in a way that has good development impact. That's a challenge going forward. Strengthened culture of learning, trying to use our research better. I've mentioned the focus on furthest behind first. And I think too, a key lesson, we can't deliver well on all 17 SDGs, so trying to focus in on a smaller number and deliver well on that smaller number. That's kind of where we're at. We would expect the policy, would hope to have a first draft in the coming weeks, and we'd hope to have a policy to share with the public in early 2019, all going to plan. This slide, these are some of the figures. Some people have mentioned the finance issue, but I think these figures are pretty stark and pretty important. They're a little bit dated. They're from they're WHO figures from 2015. And in Ireland, we were spending $4,757 per capita. And we weren't, whereas Sarah has very clearly pointed out, we're not delivering universal health care or coverage on that budget. And then when we look down at what we call our KPCs, there's 8 countries that we focus a lot of our efforts on. Look at their budgets per capita spend on healthcare. Malawi, just alluded to there. Those budgets are minuscule. You're trying to deliver universal healthcare for $34 a year per capita. In Ethiopia, $24. So some of the countries that are kind of heading towards middle income status, they're maybe on $60, $70. I think the WHO, the most recent figure I could find on this, they suggest that you need about $44 per capita to deliver some semblance of universal health coverage, and very much primary healthcare focused. So a lot of them don't even reach that. And those figures again, it's stark. My first assignment with Irish Aid was in Ethiopia, and as part of our support to Ethiopia, we used to deliver about $1 million a year to 2 of the districts, one in the north and one in the south, Tigray in the north, SNNPR in the south of Ethiopia. And on an annual basis, we would get their report on what they had done with our 1 million in the previous year, and then we'd negotiate what it is they would do for the following year. Straightforward enough. And my counterparts there, Dr. Shifaru in the south, Dr. Thiedros in the north, we'd sit down and we'd try and make that budget stretch, and we'd try to do the best thing possible with it. And what I would say coming out of those processes and having been engaged hands-on for that 3-4 years, the value that we got for that money, it was minuscule money, but what we got for it was astounding, particularly in Tigray in the north, where they had a very, very good primary healthcare system. A lot of it dependent on volunteers and community health workers, but it was amazing what we got for that money. And I had no problem defending the money we were spending and arguing for more money. But more money, it's quite limited with what we're getting. Just to move on from that as well, this is trying to look at the spend and the need. So here, that may be hard to see, but just to give you for me, the takeout from that, the OECD countries, the 36 OECD members, the rich club, if you will, we spend about 82% of the global health spend. And we have about 18% of the population. And then the green little thingy there is the disability adjusted life years, basically the kind of disease burden or an indicator of the disease burden that are in those countries. So Africa is there on the left. So you're seeing they're accounting for about 1% of the global health budget, and they've got about 24% of the global health need, if you will. Oops, I'm in the water. And then, sorry, the red line in the middle is the population issue. And again, just to put it in contrast, the Ethiopian budget for health, back in 2015, I tried to dig out that figure, it's about 2.5 billion. And that again, so it's 2.5 billion to deliver healthcare to a population, they've just topped the 100 million recently. And here we are at home, struggling, trying to deliver healthcare. to 4.5 million people on 16 billion. That's a hell of a contrast. But yeah, that's the challenge that we have and we face in our development efforts. So when we get out there and when we engage with these health systems, trying to get value for money, but I would argue as well, it's hard to make that money stretch to do what it is we'd like it to do, given the volumes that are there. I didn't take Rory's advice to switch off the phone. No. Caught rapid. Anyway, look, what about all of this? Just I thought it is something that I should throw out there at this opening session. I think these are some of the kind of, Sarah mentioned earlier, I think, some of the issues, and finance is one. It's key, I think. So yeah, I'm just conscious. I think the global health budget is about 7 trillion. It's probably enough to get us to deliver UHC, but it's where it is, how it's spent. I think there's a need to have a real good look at that. Right, moving back to our health engagement. Just to say a few things on that. Our support, our focus over recent years has been on building health systems, strong focus on immunisation and human resources. Also supporting the development of products to prevent and treat diseases of poverty, a lot of the neglected diseases as they're called, putting money into that. Building capacity and fostering collaboration between Ireland and the KPCs, and I've just mentioned some of how that happens at country level. Mobilisation of Irish domestic partnerships. Again, yeah, there's a huge value in that, I think, and we can bring a lot from Ireland to the developing countries. Improving the effectiveness and efficiency of the Global Fund for AIDS, Tuberculosis and Malaria. That would be our biggest financial commitment. And reducing vulnerability and empowering women in the fight against HIV and AIDS with a focus on prevention. Those are kind of the key areas we've been working on. Again, how we deliver it's the country programmes in KPCs. A lot of those would have a health component. At head office level, the global health and HIV AIDS partnerships that we've been focusing on, as I said, GFATM being the biggest, 14.5 million in 2018. Product development partnerships, mainly Gavi with that, 3.275 million. And then the domestic health partnerships, about 635,000 a year. And also then civil society partnerships, working with the likes of Oxfam, Concern, Goal on their health work. Health expenditure. Health is the second largest area of expenditure after our humanitarian support. It's dropped a little bit over the recent years. It's kind of steady now at about 80 million a year. And I'd like to think, again, as our budgets start to grow and as we start moving to 0.7, that we can get that going in the right direction again. Future priorities, maintaining political and financial support for universal healthcare, ensuring no one is left behind, and as I said, going a little bit further than that and putting the furthest behind first. Increasing support and follow-through commitments to health system strengthening and sustainability. I think a maintained focus on health system strengthening. And then a strong focus on key at-risk and marginalised populations, and strengthened support to reproductive health and family planning. Just there's been a lot happening in that space, US, the whole lot, and trying to see, and with our recent referendum, it kind of changes our position too on some of these health issues, so there may be an opportunity to expand and do a little bit more there. And that whole of government approach to global health and HIV/AIDS, just trying to ensure that we deliver a coherent with national, what we're doing nationally. Ideally, we'd be delivering universal healthcare nationally before. I'm always happiest out there advocating for things we've done well at home, rather than stuff we haven't yet delivered at home, and we're trying to get partner countries to move on. But yeah, hopefully we make more progress domestically and we can push harder internationally as well. So that's me. Thank you very much for listening.
Thank you very much, Aidan. Now, my only two questions have been from this side of the room, and in fact, from the same line. So I'm worried I'm leaving these people behind. So I'm going to look at you. Here it comes. Thank you very much. A question for Aidan.
Hi, thank you very much for that. That was very interesting. I just noticed early on, you mentioned about the importance of climate change and how that had been raised. But also, when you came to your priorities, I didn't see anything there which was focusing on the biggest environmental threat to health, which is household air pollution. Household air pollution. So, and scaling up to cleaner fuels. I just wondered whether that was something that you were looking at prioritising?
Yeah, no, it's hard in one slide to kind of say what we're doing and whether that falls under our health focus or whether it falls under our climate engagement. In Malawi, we've spent a lot of time and effort in the government set a target of reaching 2 million homes, effectively putting out 2 million cook stoves by 2020. And we've been probably the key supporter from a donor perspective in reaching that target. So absolutely, that indoor air pollution, it's a killer. It's a real issue. So we're doing that definitely in Malawi. We've also some support in Ethiopia on stoves. So yeah, it's a good area. Energy, I think, is a key issue going forward as well. Economies grow when they have a good energy source. And in Malawi presently, I think 10% of people have access to the grid. 90% are in the dark. And I think it's not just about stoves, it's also about solar lighting. I think there is now the technologies that we can start addressing the energy issue at household level. It probably won't be done through the health lens, it's more likely to be done under or through a kind of a climate lens, climate energy lens. Thanks.
Thank you for that. Anyone? Okay, I'm not seeing it here. I'm going to go over here for one last question, sorry. Then there will be time in the
I just want to ask Mr. Fitzpatrick, are you doing anything to monitor the amount of voluntary work that is going out to Africa to help in the health arena? I'm specifically thinking about all of our healthcare professionals who for various reasons are currently exiting our health system, and some of them are voluntary, taking on trips abroad just to support the local people because they can feel they can make a big difference there. Is the department monitoring that at all or making any suggestions?
Thank you.
No, to be honest, we're not monitoring it or keeping track of it, but I'm aware of it. And again, from the Malawian experience, I think recently I saw an email from our ambassador there saying I think there was 6 or 7 interventions in the health space. Now in Malawi, the health sector is not one of the sectors we've focused on, but he was very much aware of numerous Irish NGOs, generally small NGOs, but making a substantive difference as well. There's one on the lake in Malawi that basically a health centre that's been entirely funded by mainly the population around Dingle and Kerry, I think. So yeah, there's a lot going on in that space. How we might harness it better, how we might get it together in a more coherent fashion, that's a challenge. And I know when these people pass through, we encourage everyone to call in on the ambassador. There generally are open houses. I'm not giving an open invitation to drop into your local ambassador, but they're generally, we have a very open door policy, and we at a minimum like to know what's going on. And ideally, if we can support, if there's particular issues that might arise, we're there to support. But yeah, we probably could do better in recognizing and tapping that increasing resource that is there.
Okay, maybe we can further discuss. Guys, I think we have to finish up here. It's 3 o'clock and you are going into workshops now. And before I ask you to say thanks to this excellent panel, I'm going to help you with your workshops. Those of you who are going to the panel on NCDS and nutrition, it's in the Nightingale Theatre, and you're going to go out that door and there's going to be some volunteers who are going to help you. Those of you who are coming to the panel on overcoming barriers and stigma, you're going to stay here, okay? And those of you who are looking for soapbox snapshots, leaving no one behind, you too are going to be going out that door and following some volunteers to tutorial room number 5. And with that, can I ask you to warmly thank these wonderful speakers?
Thank you. So I'm Anne Matthews, you heard from me earlier, and I'm stepping in for Nadine Ferris-France, who's in the middle here as chairperson, because she's stepping in for our colleague Steve MacDonald, who used to work for the Irish Forum for Global Health, so many people will know Steve, but he can't present that collaborative session, and because Nadine is involved in that work, she's presenting it. So rather than 2 jobs, we changed the roles. So Sorry, we've lost a little bit of time. We know it was always going to be a little bit tight, but we have until 4:15, so we have a nice hour and 5 minutes, and then you'll have somewhere else to go, or feel free to stay here for the next session. So, like I said earlier, we want this to be as participative as possible. So we did give very strict instructions to the participants to speak for about 12 to 15 minutes max. So we'll still have a good bit of time for discussion. Obviously, if they speak for less, that's fine as well. But we will halt them at 15 minutes. I'm delighted. I would have been at this session anyway. It's about overcoming barriers and stigma. We have 3 brilliant speakers. Caitlin Walker from the University of Cambridge. She's looking at investigating prevention of depression in young people using e-health strategies. That's a narrative review. Nadine Ferris-France from the Work for Change in this context is looking at a TB, a toolkit of interventions against self-stigma. And Brugha Gahan from Concern Worldwide is including HIV is being left behind, and that's something that's come up in our discussions already, especially affecting the poorest people living with HIV and affected populations. So we'll take each of the speakers. If there are any burning questions, maybe we'll take them afterwards, but if not, yeah, it would be lovely if you didn't mind moving in a little bit, but but if you're happy there, that's okay. Okay, so first of all, I'm going to ask Caitlin to take the podium.
Looks like it's all already.
Great, okay.
So just next. Thank you. Okay, so hi, thanks for having me, everybody. I wasn't really expecting an introduction, but yeah, I'm from Cambridge University, and the review that I've been working on is looking at how e-health can potentially be used in the prevention of mental health in young people. So you probably, hopefully heard of e-health, but in case you haven't, this is the use of information and communications technology in healthcare. And this has been discussed quite a lot in terms of the ways that it can overcome barriers to care and reduce stigma, so hopefully it's relevant. So I want to first of all talk about why we focused on each of the things that we did, because our review might sound a bit specific. So why should we see mental health as a priority area? In 2015, the Global Burden of Diseases study found that mental, neurological, and substance use disorders accounted for 27% of years lived with disability worldwide. So why should we focus on young people? Well, half of mental health disorders begin before the age of 14. This is the leading cause of disability in young people worldwide. I don't really think there can be a more convincing case for focusing on this age group, but also because we're focusing on e-health, it's kind of key that they are keen on technology. So why should we focus on prevention rather than treatment? Well, the capacity and reach of treatment is fairly limited, as is the efficacy of the treatment even when it is received. And the treatment gap refers to individuals with mental illness but who are not receiving minimally effective care. So this was estimated by the World Health Organization to be 75% in low and middle income countries, and just in depression. And the cost effectiveness of prevention also makes it something important to look at. In our case specifically, we found that a lot of the literature only really looked at treatment when it was talking about e-health, so we decided that prevention was also something key to look at. So why are we turning to e-health in order to solve these problems? Well, the benefits claimed to be associated with e-health are things like privacy, accessibility, affordability, and acceptability. So these do cause e-health to offer great potential to overcome barriers and stigma. At least they should do. But there's really an open discussion about this. All of the problems that we've discussed previously are really well known, and this is much more of an unknown. So e-health has already received a huge amount of attention in policy making on a global level already, such as in the EU and the World Health Organization. Ireland itself also released an e-health strategy document for the first time in 2015, and an aim of this was to facilitate socioeconomic inclusion and equality. So although it seems relevant, it doesn't really talk that much about mental health, so we'll move on. There's an undeniable case for prevention in mental health in young people. However, e-health has not really got this level of certainty. So we were left with some questions, and we wanted to have a look. We weren't sure how different age groups would be targeted, and whether there'd be age-specific tools that were available. Would these target a specific level of severity of the disorders? Would prevention be a clear priority? How could the efficacy of these tools actually be looked at? And could these be culturally adapted to different settings? So how did we go about analysing the literature? Well, we chose to do a narrative review because we thought that this would give us the best framework for discussing the problems that we were seeing and examining the methods of the papers and bringing in some ideas of best practices rather than being so constrained. Our methods can pretty much be split into two sections. So firstly, we searched PubMed for terms related to e-health, stress, anxiety or depression, prevention, and young people. So although we primarily wanted to focus on depression, we also realized that some of the techniques underlying some of the techniques used to prevent these other mental illnesses would overlap, so we included stress and anxiety. For the second part of the study, we also ran a search of the term depression in the Apple App Store and in Google Play, and then we followed this up by searches for any publications that might be related to the effectiveness of these apps. And we did this because we thought that maybe these studies wouldn't find their way into something like PubMed. And we were definitely right about that. So on to some of the results. We'll start with PubMed, and these outcomes aren't really the main focus, but I do think it's worth a brief look to sort of understand what we were looking at. So overall, we found that 39 of the studies did report at least one significant effect of the use of their e-health tool, whereas 12 didn't. But there's so many problems with making this brief summary. It doesn't really make that much sense, to be honest, because there were so many differences between all of the studies in terms of the measurement tool that they used, the duration of the follow-up, the duration of the trial itself, the effect sizes that were found in each study were different, and also a lot of studies reported a mixture of significant and non-significant effects. So it was all a bit of a muddle and it can't really be collated, but this is just a bit of a gist of what we were finding. So then in terms of the searches that we carried out in the app stores, we carried out searches for 250 apps from Google Play and the 6 to appear in the Apple App Store. So the top graph, I really hope you can see, I don't know if you can, it's a bit small. So this shows what each category what each category these apps fall into. So the middle, this is terrible to describe, but we can see basically the prevention is really neglected. We only found 5 apps that were looking at prevention, compared to 123 that were focusing just on treatment, and then there was 34 that were a combination of the two. The graph that's below that shows the same categories, and it's for the same apps, but this shows only the apps that had any level of associated research that goes beyond just the user's review of the apps. So we actually only found 9 of these in total. Only 9 of the apps had any level of research to go along with them. And a lot of these were still in progress, and some didn't actually find significant results anyway, so we're not even saying that 9 of these found to be supported. It's really quite common to have the user preferences evaluated of the apps. It's just not to actually have any measure of efficacy. So even the NHS has an app recommendations website, and this lists 18 apps for mental health. However, the apps that the developers that apply for this, they fill out a digital assessment form, which it seems possible to complete using an expert review, and missing information can be explained, but there's no trial needed to appear on this. So what do we actually recommend from this? This slide basically is my way of summing up a problem that we kept coming across in the literature. There's such a variety of terms used, and there doesn't really seem to be any consistency in what they're used to mean. To what extent does subclinical differ from at-risk? And then where does the general population lie along this? It's really difficult to deduce whether authors and developers had much certainty over who they were trying to target and what their aim was to do. Do they know if they're aiming to prevent depression or increase well-being? And would the strategies for doing these things be the same? Well, it's very unclear. There's a lot of unanswered questions that are left. The fact is that this spectrum shows a lot of overlap, and there's different categories, but it's something that people probably do need to understand or at least have an awareness of before they set out into developing apps or policy making or into research into this. So also due to these differences, there's another problem because the scales that are used to measure the outcomes kind of need to be validated in a suitable population. For example, you can't, in our case, it's not really suitable to take a tool that's used to measure depressive outcomes in a clinical population and apply it to this because of floor effects. We also found that there was over 100 different measurement scales used in our studies. And I mean, we had 51 studies, so 100 different measurement scales really does seem a bit excessive, and it makes it far more difficult to compare what's going on. It seems unnecessary. Okay, so this is looking only at the results from PubMed, because as we saw before, there was only 9 from the others, it's a bit limited. So the left, the graph on the left shows the length of follow-up for each trial. I hope you can see the numbers on the bottom, but if you can't, it's 0 to 18 weeks on the far left and 37 to 54 weeks on the far right of the left graph. So what we can't actually see from this is that 12 studies had no follow-up measure at all, and this is especially a problem if the duration of the trial is really short. So two trials were only 2 weeks long in total, which I really don't know what we can actually conclude from those. Without a follow-up, it doesn't show anything about long-term effects. But some did include long enough follow-ups. It's varied. And then on the right, this shows the percentage of participants remaining at each stage of the trial. So there's 100% at the beginning of the trial, obviously, and then up to post-test and follow-up. Although this doesn't really look like a massive problem from the graph, we found that this was by far the most common reason why studies would say that they found only a small effect or that they didn't find an effect. It was always put down to low adherence. In fact, this was actually the last line of most abstracts, just saying that the adherence was too bad to have these conclusions. It did vary a lot, so it wasn't a problem in all studies, and actually one study only had a 1% continuation rate up until the follow-up, so I really don't know what we can actually say conclusively from that. I think adherence is definitely a problem in eHealth because participants can complete these things in their own time, and also, that they're anonymous, so they're not having to attend sessions in the same way. Okay, I mentioned the treatment gap and how eHealth is cheap, widely accessible, and possible to be used in resource-poor settings. So this finding was really disappointing. We didn't find a single trial that wasn't from a high-income country. This isn't really what we're expecting at all, but it is kind of a general trend that seems to be observed in the literature. It's kind of a bias. So from these studies, are we really in a position to know how effective eHealth could be for mental health around the world? Culture and community would really need to be taken into account, but from our study, we're just not finding any evidence of this being looked at yet. This doesn't mean that eHealth isn't being used at all around the world. It definitely is, but we're looking at a specific case in mental health and specifically of young people. So, there is even an MHGAP app, which is specifically trying to target the treatment gap in low-income countries. But this hasn't shown up in any of our research, so I don't know how well it's been evaluated or, in some cases, eHealth is being planned to be used in this way, but we're definitely finding a lack of this. So I want to sum up with this thought, and it's fairly well supported by other literature on eHealth. Firstly, for the developers, apps are quick and cheap to produce. The process of doing a review for them is time-consuming, costly, and pretty much unnecessary. The most important aspect for them is the user preferences, and they're already evaluating these along with surveys in the apps. I think it's pretty tempting for them not to test the techniques that they're using. It even sounds almost like this is valid, because often tools will say something along the lines of, based on the principles of CBT. Now, obviously, cognitive behavioral therapy is well tried and tested as a technique, but then when principles from this are taken out and then delivered to a participant at times whenever they choose, without any healthcare professional and just through technology, is not really a valid assumption that the results will be the same. Policymakers might also be quick to jump on the use of eHealth because it's cost-effective and highly scalable. And they're often also taking some of the research into the account, but this isn't really being done to the extent which could maximize the effectiveness of eHealth. That's what we're finding. So the research as well is also really lacking studies of efficacy. I think kind of what's being done is similar to measuring whether people like the taste of antidepressants, and it's just really missing the point. So, an example, the findings that we're getting from research are not very clear, and they're also not presenting in a way that are really designed for app developers and policymakers to be using, which isn't helpful. And then, an example of this is that only one of the studies that we found actually looked at the cost of the whole overall trial. So obviously for developers that would be something that's important, but the cost isn't being reported at all. So overall, I really don't think our findings call for an end of eHealth. It sounds negative, but that's not what we're saying. There's an enormous potential, but the design and testing shouldn't be left in the hands of developers. More work needs to be done in order for eHealth to be used in a way that's as effective as it really could be. So I also want to say thank you because I'm working with a partner on this project, and hopefully I said the things that she would have said also. But thank you.
Just wondering if anybody has an initial question, or else we can take the other two speakers. Okay, thank you. Thanks, Vicky. So now I'll invite Nadine Ferris-Price.
Yeah, so thanks everybody. So I'm here with a different hat on. I'm here in the conference in many hats, but just right now, I'm here as the director of the Work for Change, which is an organization that was established to basically address stigma, in particular self-stigma as it relates to any health issue or even human condition. And I'm presenting this on behalf of Steve MacDonald, my colleague who couldn't be here, who is involved in this work, and also Ian Hodgkin up there, and Bobby Ramakant. So I think, I'd like to start. This is about self-stigma, and it's about presenting to you a number of approaches and tools that we've been developing over the past 5 years on self-stigma and shame. But I want to start, like the name of the toolkit, from the inside out. So, when we talk about self-stigma, I just want to share my experience. I came home to Ireland about 9 years ago as a result of a divorce, and I arrived back in the country with my 2 small children. And when I was trying to settle them into school, I was looking at which school, which friends would be good friends for my children, and I was looking around and I saw a child and I thought, oh, that's perfect, she'll be perfect for my daughter. So I looked for the mom, and I found the mom, and I started talking to the mom. Hi, how are you? We're just newly home, what's your name? And we were walking home from school, and the mom said to me, what does your husband do? And it was like in that moment, it was like my world stopped. In that moment, what was going on for me was, oh my God, if I tell her that I'm nearly divorced, she's not going to let her child play with my child. She's going to think there's something wrong with me. She's not going to let her child come to my house. She's going to think I'm a failure. I am a failure. There is something wrong with me. And all of these thoughts were running as she asked this question. And so I have like a second to respond to this question. And in that moment, it's like I respond and I say, he's a scientist. True. True. What I didn't say was, he's a scientist and we're nearly coming to a divorce. And I went, and I could not get away from her quick enough. I mean, if your ground could have opened up and swallowed me, I was like, get out of there quickly. I just thought, I never want to speak to that woman again, ever. And I went home that night and I thought, what the hell was that? Like, what is that thing? And I started really looking deeply at what I was believing that she was thinking of me in that moment. And what I came to see was, by looking deeply in my own work, was that woman just asked me a question. A simple question, a friendly question, what does your husband do? But I believed that what she meant by that question, it was me that put the meaning on that. So it was me that was actually stigmatizing myself, and that's what self-stigma feels like. And I noticed in that moment that I was unable to talk to her. I wanted to get away from her. I felt so small and so insignificant as a person, and it was the most powerful feeling I've ever experienced internally. And in a way, I just wanted to share that with you, because all of the work that I've been involved in has come from that experience, so from the inside out. And one of the things I also like to do is like ask every one of you here, I just invite you just for a second, just close your eyes for a second, and ask you just to consider, have you ever had the thought, I'm not good enough? And if you have had that thought, just raise your hand with your eyes closed. Just raise your hand. And now keep your hand in the air and just look around the room. So it's like, here we have a room full of self-stigma experts. We know what this feels like. We know what it's like to feel not good enough, or to think that somebody else thinks we're not good enough. I'd love to just leave this with you as well. If I don't think I'm bad, why would I think you think I'm bad? So if I don't think I'm bad, why would I think you think I'm bad? I wouldn't. I wouldn't. So self-stigma, self-stigma, it's complex. Stigma is complex, but self-stigma itself, I love this definition by Justice Edwin Cameron, one of the first High Court Justice in South Africa, HIV-positive justice, that self-stigma is self-disabling inner feelings of contamination, self-rejection, and self-loathing experienced by people who have HIV or TB, even when there is no objective reason to fear rejection or discrimination, and even when there is good objective reason to believe that they will receive external support, protection, treatment, and acceptance. That's self-stigma. In terms of factors that move around from self-stigma, you have the self and what I think about me, my judgments on myself. You have society and stereotypes and what society judges. And then you also have the context and the environment with which I've come from. And all of these factors come together to make self-stigma such a big issue for many, many individuals around the world. In relation to TB, which is what I'm going to focus on today, tuberculosis, what the beliefs look like in self-stigma is, I have TB because I'm weak. I have TB because I'm not good enough. And then how I feel when I have those kind of beliefs is, I'm ashamed because I have TB. And then what are the actions that happen, either what I do or don't do? I don't go to the clinic because people will see me there and they'll know I have TB, so I'd rather not go and get the medication. That's how strong this moves inside of me. In terms of self-stigma, and just stigma in general, we're really used to stigma. We're used to talking about stigma, and this is like looking at the levels of stigma. It's the ecological model. Many of you might know it as a public health approach kind of purported by WHO. There's the individual level, the family level, the community level, and the structural level. And we are always looking at social stigma. We're trying very hard to change laws and policies, really important, to mobilize communities, to increase awareness so that people understand issues, understand what it is to have HIV or how to work with people with TB. And then there's the individual level. And what the work that we're doing on self-stigma really is at the individual level. In terms of self-stigma, just looking at some of the impacts there, at the structural level, what that means when I'm feeling that self-stigma is that I don't undertake some of the life opportunities that I could take. At the community level, it means that I'm anticipating or perceiving gossip or negative attitudes or even abuse. At the family level, or the wider family level, it means I'm withdrawing myself socially. And at the individual level, it can mean that I withdraw from care services and that I really live my life as if I'm less than other people, most people. And the outcomes of that are really, really severe. And evidence has shown, we have research that backs this up in many of the health fields. It reduces quality of life. It impacts greatly on my self-esteem, on my self-efficacy, and it increases depression. And just in terms of beliefs, like what are those beliefs when I'm really, really in touch with self-stigma? It's beliefs like I don't deserve to be loved. I feel like a burden to other people. I'm dirty. I'm less of a person. I feel unclean. I can't touch other people. It's a punishment from God. These are really big, heavy beliefs for people living with TB, HIV, and other conditions. So today, just talking about self-stigma and tuberculosis, we know that 1.6 million deaths worldwide have happened in 2017 have occurred from TB. And we know that 0.3 million of those people are also living with HIV. It's a highly stigmatized condition, tuberculosis, has been for many, many years, including in Ireland. When Ireland was very prevalent in HIV, it was highly stigmatized. What we set about to do in terms of our work on TB was based on our work on HIV, which I'll talk about just briefly in a minute. We decided to create a toolkit that could be used by NGOs or by national TB, by TB partners in countries to actually help people with TB and TB survivors deal with their self-stigma. So what we did was, it's a toolkit that is basically a workshop-based delivery. It's informational, it's got a lot of self-learning and group exercises components in there. And we drew from our own existing experience and from many different international organizations out there who have been working on mental illness, HIV, tuberculosis, gender-based violence, and other stigmatized conditions. So what does the toolkit look like? There are 8 modules in the toolkit. It starts off with the first module being, how do you understand self-stigma? So what I've seen, I was in Chennai 3 weeks ago working on TB and self-stigma, and I was working with TB survivors, and one woman stood up and she said, I can't believe that this is self-stigma. I didn't know what this was. She had TB 20 years ago, and she said, I've been feeling it ever since, but I didn't know that there was a thing called self-stigma. And now I see, my God, you're doing all of this work. People are actually care, and they're doing this work to try and help this issue. So the first issue is actually understanding what is self-stigma. After that, in Module 2, there's a module that really goes deep into the aspects of self-stigma and shame and how that shows up inside of me, looking at my beliefs around that, looking at how do I inquire into my beliefs, all sorts of different methodologies to look at that. Modules 3 to 6 looks at some of the practical aspects of my life with TB, infection control, drug-resistant TB, and my rights in relation to TB. And then the last module is like moving forward. So after my TB journey, how do I move forward from there? Inside the toolkit, just an example of some of the things, we start off with some of just looking across the world at where TB is and where self-stigma occurs and some of the statistics there. There are some beautiful practical exercises like journaling, which really just support participants to just get in touch with how they feel and what the journey of TB has been like for them. There are some exercises in there that are designed to help people really identify those beliefs and look at, if that's a belief that I have, what's caused the belief? If it's a belief like I'm dirty, what was the cause of that belief? And then if I do carry that belief, what's the consequence? How does that impact and show up, and how does that affect my life? And then looking at, okay, well, how would I turn that around and look at it in different perspectives? There's taught work, group work, some case studies, a whole load of traditional and innovative types of methodologies. It's extremely practical. It's also quite fun. Ian, who's in the back of the room, was out in Kazakhstan 4 weeks ago, testing this toolkit with a group of TB survivors. And they had so much fun with a game on TB. So this is a game that really starts to tease out, what's true, what's not true, how am I stigmatizing myself, how am I not, how does it feel? So a lot of fun was had there. This just shows you the depth of the toolkit. Is easy for people to pick up. It has everything that you need as a facilitator who could facilitate trainings. It has the materials that you need, how long different exercises take, what you should expect to get from each exercise. Here's a picture actually of Steve and the team out in Kazakhstan. It was just on the 11th of September. And you see that they were using, different ways. They were drawing and trying to tease out what did self-stigma mean for them. Some of the insights that from the Almaty workshop were the interactivity was greatly appreciated. The games and group exercises helped people, keep high levels of attention. I thought this was particularly relevant because when you're working with TB survivors and TB patients, they're all taking medication that have quite severe side effects that can make people really very drowsy. So if you're going to be working on programs and interventions around, with people with TB and HIV for that matter, it's important that those exercises there's movement there. Just looking ahead, we got a grant recently from the Stop TB Partnership to work with a great organization in Indonesia called KNCV, and we will be going to test the toolkit in Indonesia at the end of November. This time we're going to start with the training of trainers. So we'll train the trainers locally, and then the local trainers who are also going to be TB survivors will then go and deliver the training themselves. It's a 4-day training in total, and then we will do quite a rigorous process and impact evaluation to see Is it effective? How does it change anything in terms of self-stigma and shame for people? In terms of how it fits into the bigger picture, we're working on at the moment with many partners globally to try and change TB stigma. And there's a number of tools and interventions that are starting to be produced as a package. There is an assessment guide, a measurement guide for researchers, which is like an encyclopedia that thick that shows, talking of, as Caitlin was, of scales, all the scales you could possibly imagine to measure stigma in there. Then there is different individual level interventions. There's the photo voice intervention, which some of you may have heard of, and then there is the toolkit that I've just described to you, and then another program that we've been working on in Zimbabwe, which I'll just talk to briefly. That's at the individual level. At the facilities level, there's a toolkit that works with healthcare workers. So many of us know, working on stigma, that a lot of the stigma occurs in the health sector. When finally you have the courage to walk into the health sector, if you then meet a health worker who is going to stigmatize you or not treat you well, likelihood is you're going to leave the health center, or if you do take the medication, you won't come back. So there's a toolkit specifically designed for healthcare workers, and then there's another toolkit working at the level of communities to change attitudes and practices at the community level. So it's quite a global effort. The Global Fund is very interested in this work, as is the Stop TB Partnership. And for me, what I really love about it is it's very practical. And as much as I like the research to be informed and to inform our interventions by research, I really love to see that it's practical and it actually makes a difference in people's lives. Just briefly, this recent work on TB was informed by our work over the past 5 years together with Trokra in Zimbabwe on self-stigma, where we designed a 12-session course based on the work of Byron Katie, which is a method of really looking at your thoughts and your thinking. And we evaluated that with quite rigorous methods of research and showed a huge impact in quality of life, depression and things like that. We also designed another course on gender-based violence to work on self-stigma and shame among women who have been experiencing high levels of gender-based violence. So just to say thank you to all of the amazing partners that are working together to do something about an issue that many people haven't even thought about before. And I'd love any of you who want to get involved, please talk to myself or Ian over there. So thank you.
Thank you. Next we have Brugha Gahan from Concern. You'll know from Brugha already that she'll not let us ever forget HIV from our discussions of global health, rightly so. Oh.
To reach me. You introduce yourself. Yeah. Take off my glasses to see. Full screen. Full screen. Oh. Oh, is it? No, it's not.
It's the first slide. It's fine. The first slide is the presentation.
Okay. Thanks, yeah. Can you hear me now?
Yeah.
Yeah, I'm tall enough, thanks. Thank you. So yeah, thanks to be here, and thanks for the session on barriers and stigma. In fact, I have a lot in common with the presentations from Caitlin on depression, which still is stigmatized in Ireland, I would say, and certainly in low and middle income countries. And likewise TB, most people here are too young to remember TB in Ireland. As a nurse midwife, I do, but I haven't seen that much of it in Ireland. It was worse when I spent 3 years in Cambodia after the war. I mean, I'd never seen so much TB, and it's still a very stigmatizing disease, even more so if somebody's living with HIV and TB. So a number of the issues that have been mentioned, I'll be referring to. Here we are. So the title of my presentation is HIV is being left behind, especially that affecting poorest people living with HIV and affected populations. And I still stagger to check every time that AIDS is still the leading cause of death among young people aged 10 to 24 in Africa, and the second leading cause globally. Young women, due to economic, biological, social, gender, violence risks and vulnerabilities, are twice as likely to acquire HIV as young men. The SDG 3 goal, I see it over there, ensure healthy lives, promote well-being for all at all ages. And in terms of HIV, it's target 3.3. By 2030, not that far away, end the epidemics of AIDS, TB, malaria, and neglected tropical diseases, and combat hepatitis, waterborne diseases, and other communicable diseases. So a lot to do in the, is it 12 years? Am I counting right? Only 12 years to achieve all that. Was anybody here for my presentation on feedback from the AIDS conference in Amsterdam? Yep. Couple were, great, yeah. Well, the next slide does refer to that because I think it's relevant in terms of my title, AIDS is being left behind. There was a Lancet special commission produced just before the AIDS conference in Amsterdam this year, and that they said that the HIV and AIDS community, those of us here who are part of it, made a serious error by pursuing the end of AIDS message. The world is not on track to end AIDS by 2030. In 2017, almost 37 million people living with HIV globally. 75% of people living with HIV know their status, so that's good. 25% obviously do not. Of the people who know their status, 59% are on antiretroviral therapy globally, but 40%, just over 40% of people living with HIV, those who know their status and those who have never been tested, are not on ART. That means they're infectious to themselves, to others, and their immune system can be compromised. They're much more susceptible to contracting TB and other infectious diseases. As Aidan Fitzpatrick alluded to earlier, HIV and health funding globally has remained flat in recent years. If you're interested, that copy of the Lancet Special Commission, I don't have it on my I didn't bring my laptop today, but you can download it if you're on the Lancet, or I can pass it to anybody who wants it. It's a very good report. Also at the AIDS conference, they brought up the fact that there's a HIV prevention crisis. Globally, new infections have just declined by 18% since 2010, far less than the predicted 75% reduction that must be achieved by 2020, 2 years to go. Not on track. There's a condom crisis, they argued, at the centre, and I would say an ongoing condom stigma crisis. The head of UNAIDS senior advisor said, we're missing out on a cost-effective opportunity to maximise the contribution of condoms to reducing HIV infections, STIs, and unintended pregnancies. I'm a nurse, I'm a midwife, Mater Coombe James's. Since way back, I would say there's a stigmatisation of condoms here in Ireland. And they're the safest, cheapest way to protect adolescents and young people from unplanned parenthood, not just pregnancy. Young men now can be found through DNA, fathers, STIs, HIV, and what we're hearing about more recently, cervical cancers, affecting men and women. And I mean, it is an advocacy issue in Ireland. We need to get the value-added tax scrapped off condoms. There is still a condom stigma. If you go to Tesco, they're locked behind a glass case. You can buy your vegetables pretty easily, but it's pretty hard if you're 17, you're trying to buy condoms. And even the costs in terms of a can of beer and condoms, it's ridiculous. Non-invasive, no injections, no medication, maybe random unprotected sex planned at a weekend or something. Why are they not more easily available to prevent young people contracting unintended parenthood, STI, HIV, and cervical cancers? I think we all can do a lot more to talk to Simon Harris and whoever can make that happen. That lady this morning, what was her name? Sara Burke. The Global HIV Prevention Coalition brought together leaders at the conference to call for accelerated action. Again, HIV prevention funding has put the end of AIDS at risk. In low and middle income countries, there's certainly a stigma around condoms. They're not easily available. I jokingly argue that in Sierra Leone and Liberia, which now thankfully have got beyond the current recent Ebola crisis, their main export is rubber. Where are the businesses helping them to produce condoms locally in country and employ young people? You know, imported condoms brought from the USA through Irish Aid Fund, the Global Fund, PEPFAR, whatever. Huge cost to import them across the world. And then the green issues, the Green Mile, climate issues. You know, we need to support that these can be produced in country to protect young people from the same infections that we're susceptible to here in Ireland. Unplanned pregnancy, parenthood, STI, HIV, and increasingly cervical cancer. Many of you will have seen this slide, I'm sure, from UNAIDS. They talk about the 12 populations to close the gap so that nobody is left behind. And any of us here in this room could be a member of, I think, any of these 12 populations. Let me read it here carefully. A person living with HIV, a young woman, a prisoner, a migrant, increasingly on our radars, an injecting drug user, a sex worker, more than 50, not many of us in the room more than 50, so we'll skip that one. Each person living with a disability, a displaced person, a child, a pregnant woman, a transgender woman, a man who has sex with other men. Most people in this room could be a member of any of those 12 populations. And among those 12 populations, some people are being left behind, the most vulnerable, the poorest, the least resilient. 48% of children who are HIV positive, eligible for antiretroviral medication, do not have access today. That's nearly half of the children living with HIV globally do not have access. It remains way below adult coverage. And this is a human rights issue. It's a pharma issue. Don't know anybody here from the pharma companies, Access to Essential Medicines campaign, but it costs a lot more to produce pediatric AIDS medication. So the children are being denied a right to life. Every week, and I checked last night again just to be sure, I mean, it's unbelievable that every week 7,000 young women aged 15 to 24 become infected with HIV. The drivers being gender inequality and gender-based violence factors, often younger girls with older men. Prevention and treatment efforts are not adequate to reach young men or young women. And then the whole M population, as I call them, M people, sadly on the boats, the migrants, marginalised, minority, prison population, mobile populations, pastoralists, mobile workers, let's say South African minors, MSN, men who have sex with men, most at-risk populations, sorry for all the acronyms, definitions, the UNAIDS dictionary, intravenous drug users, formal and informal sex workers, the LGBTI, lesbian, gay, bisexual, transgender, intersex people remain in the shadows. Punitive laws in many countries inhibit people accessing HIV or TB treatment. And I'll be leaving a couple of publications, but you know, this is a picture of a young man in Africa hiding his face. Many people will not show themselves to be living positively with HIV. Yesterday, going back to Concern, I forget from where, in the back alleyway, I saw a young girl, trousers down, injecting at the back of her office. I mean, that's how open it is. She disposes of a needle on the street. Somebody could walk along, step on that needle. Now, if she's not living with HIV, they won't get infected with HIV, but they are open to exposure to hepatitis or Hep B or other infections. So it's closer than we think, both here in Ireland and globally. Stigma and discrimination, these were responses that were mentioned at the AIDS conference in Amsterdam. In Eastern Europe and Central Asia, HIV and AIDS cases and deaths continue to grow, the fastest growing epidemic at the minute. They're promoting a campaign there to chase the virus, not the people. And anybody can have these slides after, you don't feel you have to write down. In Bangalore in India, a bit like an anti-stigma campaign, or anti-TB stigma, look at the champion in me, and they use sport in response to stigma and discrimination against adolescents living with HIV. Some of these adolescents were born to mothers who were HIV positive. They didn't contract it through sex. Nobody should be discriminated against because they happen to have been born living with HIV. But you know, we have more and more adolescents and young people living positively with HIV through infections from their mothers before we could prevent mother-to-child transmission. Now we're getting more successful, thankfully, here in Ireland and globally. And in healthcare settings, especially for young people, people feel they're not accepted, turned away, consent issues. I mean, the age of consent for sex in Ireland is 17. Imagine if a young boy or girl wants to go to get a HIV test at 16 without telling their parents. What might be said? And this came up at the conference, ALHIV, an adolescent living with HIV. We are not just treatment models, but human beings with sexual desires too. Tell us about safer sex beyond ARVs. How can we end discrimination in healthcare? And Nadine brought up the issue of discrimination in healthcare. There's a lot more we need to do. Avert, a website some of you know about, it's very comprehensive, an excellent site for teaching, and they have a lot of campaigns about what we could do to prevent and reduce stigma. I won't go into everything here, but it's about protection, inclusion, education, and empowerment. Advocate for action. And likewise, as with mental health, depression, stigma, you know, we need to advocate for action. There is a lot more that can be done to help people break through the walls of stigma and the barriers of non-inclusion. For me, based on my work with Concern now for 30 years this year, I was a child when I joined Concern in Sudan in 1988, but HIV is being left behind among the 12 populations. But some people among the 12 populations do have assets, they do know how to get on the internet, they have more resources than others. We need to look for the extreme poor, and especially women and young people left behind among these 12 populations. And I've been emailing UNAIDS forever about this. They need to go beyond the 12 populations to really target the depleting resources so that they reach the extreme poor and people left behind. On the last trip I went with Irish Aid and Concern doing an evaluation in a really remote area in Mozambique. It was a plane ride to get to the city, then a car ride, a boat ride, a car ride, a boat ride, a car ride to reach the population. The people there said, if I'm found to be HIV positive, I will never get treatment. The health systems aren't working here. Why would I get tested? You know, these are the remote, rural, displaced, impoverished people that need to be reached in terms of reducing HIV infection. So we need to look for the extreme poor beyond and within the 12 populations that have been identified. This is a very good publication. I just put up one slide from it, Overcoming HIV-Related Stigma and Discrimination in Healthcare Settings and Beyond. Again, directly related to Nadine's presentation. As for TB, as for HIV, stigma means delayed testing, late diagnosis, often non-disclosure, living in silence, fear, and lower treatment outcomes. Similarly for depression, people end their lives often without seeking any treatment, and especially in low and middle income countries. And this slide looks at removing stigma and discrimination that improves healthcare access for prevention, testing, and treatment. The actions that we can take. So if anybody's interested in that publication, you can hit the link on the slides afterwards. I think it's one of the best out there. On to my second last slide, really, again, back to the SDGs and overcoming barriers and stigmas, not building walls. Let's see how the elections go today in the US. We need to dispel stigma and ensuring a non-discriminatory and evidence-informed response protecting human rights. Removing policy and programmatic barriers and expanding HIV, TB, and harm reduction services to people who inject drugs. The HIV response, this was in the Lancet, must take a bolder action to remove social and structural barriers to good health. Health action is about advocacy as well. I'm a nurse midwife, but it's beyond being a practitioner. We need advocates to support the practitioners to effectively deliver the services. Going beyond the silos and integrating HIV in global health responses globally. That's part of the Lancet Commission publication in July 2018. The SDGs I was missing number 2, but I see the rest of them. 17 around the room here. They're interdependent. Health in the SDG era has relevance for each of the SDGs, and each of the SDGs has implication for best health, HIV and depression outcomes. Totally interdependent. And that panel shows how each of the SDGs has implications for health and vice versa. And this is the last slide here, coming up to World AIDS Day in 2018, marking 30 years of World AIDS Day, the 1st of December. We've just passed week 43, imagine in Ireland, and I checked the data yesterday, 424 new HIV diagnoses in Ireland to date this year. That's 10 a week being diagnosed every week in Ireland. We've passed the tipping point. In some weeks it's more than 10. I mean, you might say that's not a lot, but 424 people at this conference would be an awful lot of people who would be sitting here now living positively, I hope, on treatment with HIV. It's a lot of people. And globally, 5,000 reported every day, adults and children, in 2017. We all need to help counteract complacency and stigma, which is dangerous. The HIV theme, the World AIDS Day theme for 2018, know your status, so you see the guy there getting the test. The new UNAIDS report is looking at HIV and primary healthcare linkages and opportunities. And it's a great resource in terms of looking at the interconnectedness of primary healthcare, Alma Ata from 78 to Astana in 2018, how we can integrate better primary healthcare and the HIV responses. Anybody know what that thing, I don't know if it's a man or a woman holding in their hand in the slide there, the AIDS response and primary healthcare linkages and opportunities? Anybody figure out what it is?
Tablets.
It is, yes. It took me a while to figure it out. What is that? It's the acronym for the title of the report, and there's me, a nurse. And I went, oh yeah, Monday, Tuesday, Wednesday, Thursday. You know, so every day you have to think of taking your treatment if you've got HIV or TB for obviously what do you call it, the rapid TB treatment. Forgotten my words now, in rapid HIV treatment. Anyway, helping us to get to zero in terms of new HIV infections, discrimination, and AIDS-related deaths. So thanks for your attention, and we look forward to the questions and discussion, looking at the linkages between depression, which is a big risk, and even more so in developing countries where there is no treatment. It's not reported, it has never been documented in terms of numbers. Many people in the early days, Nadine and I were there in Asia, I was in Africa, ended their lives when they found out they had HIV. Or if they suspected they had HIV, they went into the forest to die so they wouldn't be a burden on their family. It's not recorded, there is no data, but it's a huge factor. And TB ongoing. Thanks for your attention.
Thanks, Breda. You'll be glad to know SDG 2 is at the frontier of the
Oh, is that where it is? I was looking around the room to see where it is.
hunger. So thank you very much. And as Breda's making her way back, I think, Breda, you've done my job as well, because bringing these together and thinking about barriers to access, how that links with stigma across what seem to be quite different sets of experiences for people, but actually they have a lot in common. And again, all of the speakers coming to help us identify some solutions in terms of advocacy, campaigning, research, and then very practical toolkit. So with all of that in mind, I'll ask for any comments or questions. We have a nice 10 minutes for questions. If you want to say who you are, what you're working on, if you have a question for one person or for all three, please feel free. Great, thank you.
Hi, my name is Sinead. I work with Mission Cara as a project officer for health. My question is kind of focused on prevention, particularly HIV and AIDS and STDs and reproductive health. In my experience, I found that the focus is on preventative education is on women and children, which of course is necessary, but I find that men are often reluctant to get involved in these discussions. It's seen as a women only sort of a problem, and I think in Ireland as well, as an Irish woman growing up, I remember when we were in, I think, 6th class in secondary school, the guys left the room when we went to talk about women's reproductive health or menstrual. So I just kind of want to know what your experiences are. Do you feel as though it's a gap? And
Yeah, I think actually something that this year has been more addressed through the media, and It's Okay Not to Be Okay, that kind of campaign, I think is aiming to address more males, because especially, you know, in like older age groups, it's really not something that's seen as okay to be discussed. But yeah, I don't know of much work other than that that's aiming to address more.
Okay, yeah. Thanks, Sinead. Yeah, no, I mean, absolutely, I agree. And as a midwife and working with pregnant women in developing countries, even in Ireland, among immigrant or migrant women to Ireland, unless you opt out, women are found out to be HIV positive in pregnancy, and a lot of men disappear, both in Ireland and in developing countries where concern is working. But I agree with you, increasingly we need to engage men and boys. And if ACT UP Ireland were here, they're actually, I would say, 90% male, and they're arguing about the role of men. Okay, a lot of it is men have sex with men and men as fathers, but definitely they would argue that, you know, there needs to be a united effort in terms of not men in one room or women in the other. And trust, I would say we need to trust young people, adolescent boys and girls, to be able to talk to each other. Increasingly they can. It doesn't have to be behind a screen with an app. Accurate information should not be feared by anybody. How to protect oneself from unplanned parenthood. Imagine a young boy who's 16 said, well, actually the DNA says you're the father. Can we have maintenance please now for the next 30 years? Because that's what can happen today. And I think it's a disservice to young boys and young girls if they don't have that information in an age-appropriate way, not in a negative way that it's all wrong, in an accurate way. And we need to engage with men's groups and women's groups. I remember working on a field trip one time in Nairobi in the slums, and it was actually the men's groups in Karangacho who wanted to reach out and talk more, because they felt that the women were getting all the care through antenatal care, and men felt denied because most men do not want to go to health services where it seems to be all about vaccination for children and antenatal care, safe delivery and postnatal care. So we need better ways of including men, or having maybe evening services or separate services. I'm not sure how to do it depending on the budgets available. And the same for TB. A lot of men would probably not want to go in the middle of the day when they're trying to stay working, meet the needs of their families. So the key people to help us solve these issues are, I think, the people we're working with to advise us, and the host governments we're working with, the local NGOs, to say what's the best response. But definitely we need to engage better with men and boys and young men. Any other questions? Any comments from the audience? I don't have all the solutions here.
Hi, yeah, I'm here as a master's student from the Trinity Global Health Program. I was really interested about Caitlin's presentation on e-health. I know you said that there wasn't a lot of, or any really evidence on it working in low and middle income countries. But in terms of education about HIV and TB and making sure that people have access to the information they need to get treatment and to prevent contracting the diseases, do you think there's a potential for e-health in sort of getting people that information?
Yeah, so in terms of what I was looking at, it was very specific to prevention and mental health and in young people. So that's why we weren't finding, any evidence of that. But it doesn't mean that necessarily there's no research on what's being done in TB or HIV. I do think that definitely there is a potential for that to get information out there, even if it's going to, say, like healthcare, community healthcare workers and that kind of thing. Often apps can target like people on that level rather than actually individuals if they don't have access to the technology. Yeah, but I don't know of any examples.
I have a related question in terms of when you were speaking, especially for the extreme poor e-health literacy. Like how does one overcome that? I mean, I'm not a very good app person myself. I can barely get the Dublin bus and find out where it's going. So, it's a skill, and older populations, and especially illiterate people who are not literate in any language, how can we better support them to get
so that's also absolutely a problem. I think there are ways of overcoming that. So, for example, not all of what we looked at was just specifically apps. Sometimes it's kind of telephone counselling just for people who can't actually, get themselves to the services. So yeah, it's definitely varied, but obviously language barriers and is always going to be a problem here. And even, the MHGAP app that I was talking about, that's kind of addressing getting information about diagnosis of mental health just to a few individuals within a community. So then I suppose if there's a few that can understand, then that can help disseminate. I don't know. Yeah.
I was thinking, it's not quite the same thing, but we've been doing some work in Vietnam on tuberculosis and also on stigma and self-stigma, tuberculosis and also sex work. And it came up that in Vietnam, they're at the moment in the process of developing a new app for TB patients. And what they're doing with this app is they want to use it, so they want the health workers to use it to report TB cases so that it would actually feed into surveillance. And then they want the patients to use the app for to help them with adherence and treatment, reminders about when they need to take their medication, when they need to check in. And we're talking to them about adding a whole self-care module so that some of the types of things you've seen, for instance, from that toolkit could be adapted into smaller, different ways of helping people support themselves. So the more I'm kind of finding out, I find that many countries are actually investing in these kind of apps for HIV, for tuberculosis, combining things like telephone services, apps, IEC materials. There's a lot of innovation out there, and I think we just don't know yet how effective these things are. I have every confidence with Vietnam investing in such an app that we will find out how effective they are, because they usually do things extremely well.
In India, where Lucerne in the past was supporting a HIV response program, they were using, with the National AIDS Control state, with government, texting, tracking loss to follow-up. And it proved to be very effective because people felt important when they got a text message. Simple, somebody actually is interested that they didn't see me coming back from a medication. It created a sense of well-being, especially if they said the name, a bit like when we get our hospital appointments here. Rita, the Mater Hospital expects you for your OPD. But more can be done, and well, especially for people who are literate, let's say. Or for people who are not even, like older people, there'll be somebody maybe in the family who can read it for them. But yeah, even the old Nokia can do that.
Yeah, with bundles like in Zimbabwe where you press the numbers in and yeah.
We might have one last question if anybody has anything.
Hi, my name is Maria. I just finished an internship in the WHO team in mental health and human rights. And I was very interested in the toolkit because they are actually developing a toolkit for human rights and mental health and how to empower people to, it's pretty much aligned with the desystematize ourselves. And I was curious in the toolkit and if there's any section or area that it's addressed cultural sensitivity and how the toolkit could be adapted to different cultures, especially the ones that might feel a lot of vulnerable populations might have a lot of pressure of speak up and be independent in expressing those things.
Yeah, it's a great question, always those questions. Yeah, I mean, at the moment we're just testing the toolkit, so we're learning. we're learning what works, and I'm also very grateful that not only did people invest in the toolkit, but they invested in the testing of it, because you produce something and then let's see how it works. There's definitely some modifications that need to be made, and will always need to be made from country to country, from different group to different group. That said, I would say that what's been very interesting for me over the last, I don't know, probably 10 years, is that there's no thoughts. Thoughts are universal. And beliefs are universal. And in my work, whether I'm working in Vietnam, whether I'm working in Zimbabwe, whether I'm working in Cambodia, in Ireland, any country that I've been working in, the beliefs are the same. And so while they might play out differently in terms of the culture and what they mean and how much weight is placed on different beliefs, in terms of how people see themselves, that can be very similar. But of course it has to be adapted country by country. So happy to share with you the toolkits. They're online. Anyone can share them, which means anybody can take them and also test them and adapt them, take one little exercise from it. One of the things they said in Kazakhstan what they wanted to try and do was to start using it maybe every month, using it with a support group of TB survivors and taking one exercise per month as a way of ongoing type of mental health and support.
Does that mean it's already, there's a budget for translation? It's in Kazakh?
It would be it's in Russian, right, Ian?
Yeah.
It's in Russian, and it's also in Bahasa, Indonesian now for the next pilot. And as I said, the Global Fund, it's like WHO and the Global Fund, they're very interested in these type of interventions in helping them get out there, so.
Yeah. I think it's important also just to add to that.
Yeah.
Can you hear me okay?
Yeah.
Just to add to that, yeah, this is a toolkit that's been adapted to its culture, but also I think it's important to remember in our sector we generate dozens of toolkits by the minute. So we select the one that works best for the situation we've got. So if we've got a group of people, maybe with TB, maybe with HIV who might benefit, then we use the toolkit. We've got a different setting, different population, different demographics, then we use a different tool. So it's more kind of choosing the right one that works. And we found so far this one works quite well in groups of people who have experienced TB, but it might not work in all circumstances. So it's being selected in what you draw on to use, if that makes sense. Okay.
Thanks, Ian, for that. Well, without any further ado then, I will call this session to an end. I want to thank our three speakers, and I really want to thank everybody who asked a question. It's never easy to ask a question, and thanks to Ian for the contribution. So if you just wouldn't mind giving a warm round of applause to the three speakers. Invite you to find your next session if you like. You're welcome to stay here, and that will be, so they're starting at 4:15, which is now. So in this room we have, oh, we're not in this room, so that's excellent. So then you have to go somewhere else. So the first session is in tutorial room 8. That's on influencing empowerment and mental health. We have 4 speakers there. The next one is in the Nightingale Theatre, Health System Strengthening, sorry for all the acronyms, in emergencies. And we have 4 speakers there. And then we have some soapbox snapshots. We have 5 speakers there in tutorial room 5. So tutorial room 5, 8 and the Nightingale Theatre. So again, if you don't mind going that way towards the door, and some of our volunteers will help you, and thank you for your